Welcome back to Made to Be Whole. Stay tuned for part 2 of our discussion on urinary tract infections.
Made to Be Whole is intended for informational purposes only. It's not intended to replace the advice or care of a licensed healthcare professional. Participating in this podcast does not constitute a provider-patient relationship with Krista Michener, AHP Integrative Health, or any of the guests featured on Made to Be Whole. Krista Michener, AHP Integrative Health, and any featured guests aren't responsible for any losses, damages, or liabilities that may arise from use of information obtained in this podcast or associated materials. Please consult a healthcare professional for any health-related concerns that you are experiencing.
So last week we talked a little about the diagnosis of urinary tract infections, especially chronic infections, and the sorts of different symptom presentations that they can manifest. Today I want to talk a little bit about treating. So it's really important for me that treatment is guided by good testing. We talked about microgen and the PCR and NGS, or next generation sequencing testing that they provide. One of the things that's really great about that report, in addition to accurately identifying the pathogens, we also have a great reference for which antimicrobials will work for that pathogen and also which things there might be resistance to. So, resistance happens when you have a group of bacteria, or it could be a different sort of microbe, but that doesn't respond to standard treatment that you think it should. This is ironically one of the great arguments for not adequately treating urinary tract infections. Adequately, this is why we say, oh, don't treat if there aren't symptoms, or don't treat for more than 3 days. But in my experience, resistance develops partly because of undertreatment. If you are just treating for long enough to kind of like spit on the fire and then you walk away, that bacteria is going to get smarter. Okay. You're more likely to develop resistance. You're more likely to have biofilm formation, these entrenched microbes that are much harder to treat and then require longer courses of antibiotics down the road. That could be avoided by treating adequately early. So if somebody has an acute urinary tract infection, you haven't had one for years or ever, and you have acute symptoms, I recommend getting tested and treated if there's something there. And I would recommend treating for at least 10 days. I just don't think it makes sense to risk something becoming chronic. You will lose fewer antibiotics for less time in your life if you treat infections early and adequately. Now, one of the things that is challenging about these results is you will have somebody who has maybe 10 different bugs. I've seen more than that, but we'll use 10. It's a round number. And they are not all susceptible to the same antimicrobial. So how do you tackle that? There are a couple of different ways to do it, and it depends partly on the patient's symptoms, allergies, tolerance, that sort of thing. Very frequently, I will see in these polymicrobial infections, especially with women, I will see strains of Prevotella and Gardnerella. Both of those need to be treated with metronidazole. And somebody who has Gardnerella infection, they probably have it in the vaginal tract too. For vaginal Gardnerella, which is what causes bacterial vaginosis, there is vaginal metronidazole that can be used. But if it's in the bladder as well, in the urinary tract, you need to use oral metronidazole. So I will, if a patient is willing, frequently pair metronidazole with an antibiotic that's going to kill the other dominant bacteria. I cannot look at a list of 10 plus bacteria and frequently find that there is one or even two antibiotics that's going to hit everything on the list. So the best strategy, and this is something that Ruth Chris taught me, was you start with a dominant pathogen. You start with what's making up most of the infection, because the pathogens are listed in order of quantity, how much they're finding in that sample. So start with the low hanging fruit, start at the top of the list. And I go through and I look, first of all, does the patient have any allergies? Penicillin allergies are not uncommon, and that can throw a damper on some things. We're frequently taught in school that Bactrim and macrobid or nitrofurantoin, it's also called, are these ideal urinary tract agents. But I'm finding when I look at test results that they're not frequently what works. Frequently, what I need to use is a cephalosporin or augmentin, sometimes phosphomycin. It's not what you would typically expect. And again, you're going to save time, money, and be on fewer antibiotics for a decreased amount of time if you're actually identifying and treating the right bug instead of just squirting at something hoping that you put the fire out. So I look at that. I look at tolerance. Is this something that's known to cause a lot of side effects? If you do take metronidazole, one thing that is important to know is you cannot drink alcohol at all while you're taking it. You will be very, very, very sick to your stomach, like puking your guts out. Hate me. Most people are fine with that if you educate them, but if I have someone who's an alcoholic, I'm not going to give them metronidazole. You also have to be cautious with even tinctures or mouthwashes that might contain alcohol because it could also have that adverse effect. I look at side effects. There are some antibiotics that frequently come up as effective, but they are just not first line. So levaquin is from a group of antibiotics called fluoroquinolones. You have levaquin or levofloxacin, Cipro or ciprofloxacin, which used to be used all the time for urinary tract infections. But what we found with that category of medications is they put people at higher risk for tendon rupture, not just during the use of the antibiotic, but even down the road. Sometimes you don't have an option, and that's fine. But if I have other options, I'm going to use them. Or if there's someone who's much higher risk of a tendon rupture because they do a really high impact sport or something like that, that they're more likely to pound and pop an Achilles, I really, really want to avoid that with them. So that's kind of the tactic we take. Treat for a couple of weeks, wait a week, retest. What are we finding that's left? There are some more dramatic things that you can do. And right now, I'm still focusing more on women. I'll get a little bit to the treatment nuances with men after this. One of them is to put antibiotics directly into the bladder. We can have bladder instills made by a sterile compounding pharmacy, and they provide the antibiotic in a solution that typically has some things that can help with biofilms as well. And they will send them to you. We teach our patients how to do it, but it's something you do at home. You catheterize yourself, you squirt the antibiotic in, you hold it in for as long as you can, and then you pee it out. And even though it sounds not fun, I do have patients who we tried all sorts of things. And when we switched to the bladder instills, they did a ton better. They did so much better, and they were able to overcome their hesitations about the whole process. And it wasn't that big of a deal after a while because you get the hang of it. There are people who catheterize themselves every day because of spinal cord injuries and other things. You can learn to do it too. And the great thing about bladder stills is that you don't have systemic side effects. I mean, it's really just going to the bladder. Some of the limitations of that are not everybody is physically able to do that. If you have really severe rheumatoid arthritis in your hands, poor dexterity, if your body size makes it complicated, it's not practical for everyone. And not everyone has someone they would be comfortable asking to do that or who would feel comfortable doing it. It is an option. We do sometimes have that same pharmacy make compounded vaginal suppositories. If you have a vaginal infection that won't go away, they can make a suppository that has what you need that you just pop in at night. It stays there overnight. It can be really effective too, but it is usually cycles of treatment. The cool thing is, as dramatic as all this sounds, there's help and hope out there for people who have been told for a very long time there's nothing that they can do and that they just need to do more Kegels and Vitapens and best of luck. So, moving on to men, treating these infections in men is complicated in different ways. So, the first barrier is that it is very difficult to penetrate the prostate. So, I was trained that with a urinary tract infection in a man that you should always treat 6 to 8 weeks. I know some people do 4. I would consider that a bare minimum depending on their age and the length of their symptoms, but that is because we're not just trying to get that soft bladder wall, we're trying to get that prostate, which is more firm, and it takes longer and it's harder to penetrate the prostate. So you're automatically looking at extended treatment periods for a male because of that. The other challenges that you have is that you can have medications that come across as effective against the bacteria, but they may not penetrate the prostate. So again, it might work in a dish or it might be decent for a female with the same infection, but you have to look at medications that can actually penetrate the prostate. So you have more of a limited range of options. The bladder installations are actually not as great of an option for males simply because, again, we're looking at that prostate penetration. You can get the antibiotic up there, it can be in the bladder, it can wash over the prostate, but actually getting in there, helping fix things permanently is more of a challenge. With the men, I mentioned in our last episode, testing the semen is really important. I've tried to find ways around this. For example, I've even had patients who didn't want to do a semen sample say, well, why don't you give me a urine sample immediately after sex? Because if you just ejaculated, then there should be still some in the urine. But I still haven't found that to be as accurate. I know the approach in the urology world is that they'll massage the patient's prostate manually, which sounds really uncomfortable to me, and then have them give a urine sample. But by and large, I'm finding that these semen samples can shed a lot of light that we just can't get from other sources. So I think it is definitely a right on approach that is absolutely worth the temporary discomfort or embarrassment that that might cause. Now, how long does it take to get better? How long have you been sick? That's my answer to that question for a lot of different individuals. So if you have had symptoms for 6 months or a year, it might take a little while to get better, but you're pretty good. But if you've been having chronic UTIs for 20 years and you've been having incontinence and your life revolves around the bathroom, or you've been diagnosed with interstitial cystitis, it could definitely take more time. And I have patients who it's taken years to clear them, but you can do it. And I would really, really, really recommend that you not give up because it can become so much harder down the road. And I would also encourage people to be very attuned to their body. If something is just not normal, don't just write it off and say, "Oh, I'm getting older." We hear that all the time. "Oh, you're just getting older." So I've gone through this joy of testing, treating, retesting personally. And what I found after repeated treatment was, oh, do you know what? I don't have urgency. I never really thought of it as a pathological urgency, but when I have to go, I have to go. And I was thinking about my bladder a lot. And after successful treatment, it's just not that big of a deal. I mean, I go to the bathroom like normal people do. I'm 50, so I'm a little more careful and, go before I leave. You just want to make sure you're not caught, but it's very, very different. We mentioned for men that the impact can also include erectile dysfunction. So that's a pretty big deal that we spend a lot of money doing other things on when really a root cause could be infection. And another root cause with that can be anything that adversely affects blood flow. So decreased nitric oxide production is one. There are supplements that can increase your nitric oxide. Checking your amino acids can be really helpful because there are amino acids, specifically arginine and citrulline, which have a lot to do with blood flow. So checking that out. I'm certainly not opposed to people using Viagra or similar medications on an as needed basis. But if you have erectile dysfunction, I don't see it as just an inevitable result of aging. I see it as evidence that something's going on to impair blood flow. So, inflammation from infection or other things that are affecting your vascular system. And your vascular system isn't locally affected. So you don't have erectile dysfunction and have poor blood flow to the penis, but great blood flow everywhere else. It doesn't happen that way. So if you have that symptom, there's probably issues elsewhere in your body, and anything you can do to improve blood flow will help your cardiovascular health in general. So we've mentioned before, Neo 40 is a great supplement that increases nitric oxide levels, helps blood flow, can help erectile dysfunction in men and sexual problems with women too that are related to poor blood flow. But I would just encourage you, I guess, to dig deeper, to look at vascular health. If you smoke, if you have uncontrolled diabetes, that's going to definitely affect it. All of those things need to be addressed. I want to go through some of the symptoms of these chronic urinary tract infections other than the very common ones. We talk about urgency, we talk about frequency. So urgency, when you've got to go, you've got to go. Frequency, you have to go all the time. I've mentioned incontinence, which is a big deal. Nocturia, which is peeing at night. If somebody's peeing more than once at night, what's doing that? That's my question. I do have people who we've treated successfully for infection and they're not out all night peeing anymore. Double voiding, which is this concept of you pee, but then you're not really done, like it's coming back. Obviously, pain, blood in your urine, that needs to be investigated. Now, that's particularly important if you're postmenopausal or if you're a male. That's important. There can be non-nefarious things causing blood in your urine, but you always have to look at cancer risk. If you have blood in your urine, you test and there's no infection, you have to be looking at bladder cancer. So pay attention to that. And that again is postmenopausal women and men. Pain as your bladder fills up, or pain that doesn't go away in your bladder when you pee. And your bladder is, if you just go to your pubic bone, it's right there. It's in the lowest part of your stomach, right in the middle. Pain in your loins or your groin, which would just be like that upper inner thigh area, or if it radiates to the genitals or to your legs. General pelvic pain, vaginal pain, pain during sex, and this is for men and women. You can both have that. A weak strain, we mentioned, or straining to void to get things out, and that can be for men or women. If you think about the concept of a biofilm, which is something that's trapping all this stuff in, depending on where those biofilms land, they could be obstructing urine flow. Urine that's really smelly, that's another one. If you don't drink enough, sure, you want to first start by increasing your fluids, but if you've got foul smelling urine, what is it that we are smelling? It could be that you have some sort of infection that is stinky. Along with treatment, we mentioned previously, you have to really hit the biofilms. I talked about this a little bit before, but you've got to be aggressive at taking care of biofilms. And if you're someone who has an infection that doesn't clear despite doing the standard things for biofilms that I discussed, some of these combination enzymes, or just general standard things, we talked about it a little in the last episode, I would recommend two things. I would first of all do some specialized testing to help us determine what your biofilms are made of. And then the other thing I would do is I would check to see if you have an immune deficiency. So that can be checked with a couple of labs that can be ordered from lab, CoreQuest, whatever lab is closest to you and that your provider typically uses. But the three things that I like to check for the evaluation of someone's immune system function, and I'm not an immunologist, but I have found these to be problematic in some of my patients who just aren't getting better despite doing the right things. So immunoglobulins, and that's immunoglobulin A, E, M, and G with subclasses, a T cell panel and a B cell panel, and then an HNK1 or CD57 panel. HNK stands for natural killer cells, is the NK. All of those things can help us figure out, is there a reason why this person is doing all the right things and nothing's getting better? I have had patients who treat, and even though the improvement is slow, there's improvement, or we at least have a decreased bacterial load. It was high, then it was a medium load, and then I see the numbers getting smaller, even though there's still some bacteria present. But if they've been consistently treating and we still have a high bacterial load, the answer shouldn't be to say, well, this is a garbage test, or do you have pain when you pee? Then you're not really sick. Everybody has a non-sterile urinary tract. The the question should be, why, despite adequate treatment, do we not have a decreased bacterial load? And then seeing if, again, there's a deficiency of some of these immune cells or something underlying that can be addressed. There is treatment for those things. Some people have what's called common variable immune deficiency, where the immunoglobulins are out of whack. I have had patients have abnormal B and T cell panels, which we've checked out. There wasn't anything going on as far as cancer, because sometimes lymphoma can cause alterations in some of these labs, but we got them to the right specialist, ruled that out, and it was determined that it was chronic infection that did that, but the infection messed up their immune system. So we just have to be extra supportive of the immune system to help get them over that hump. So when I think about it, this is somewhat hopeful and somewhat depressing, but I think it's really, really important because there are so many problems that aren't just an inevitable part of aging. It's not just because you're old. And there isn't a lot that you just have to get used to and deal with. I think that we all deserve answers for what causes things that impact our health, especially when they have long term potential implications on our quality of life, our social life, intimacy, physical health. And then we are learning more and more about infections in general, setting the stage for dementia. I've mentioned before, there was a really interesting meta analysis that looked at the autopsies of patients with Alzheimer's. And when they detected those plaques that are always blamed for the pathogenesis of Alzheimer's, so what's causing it is plaque formation. But when they took the plaques apart, they found those plaques were really biofilms. It was infection, and then the body was trying to wall off the infection to protect the brain. And then you have circulation to the brain and cognitive function that are impaired by this. And really, it's all the downstream effects of something that, if identified early and appropriately treated, could have potentially been avoided. Little warning with that: Alzheimer's, just like everything else, there is not one cause, one cure. That's not the answer for everyone, but there's more and more evidence being acknowledged by the scientific community that there are infectious causes. So treating infections appropriately, early, and robustly will decrease your future dependence on antibiotics and other pharmacological agents. Because remember, with syndromes, it's just treating symptoms. It's not getting to the root cause. If you can put out the fire when it's young, you're going to have fewer complications down the road. It is a hassle. Nobody wants to have multiple rounds of treatment for a UTI if it seems like just mild, annoying symptoms, but those could develop into something more. So I would encourage, if you have the bandwidth to do it, if you have some of these annoying chronic symptoms, that you dig a little deeper, see if there's an infection going on, and take care of it. I've mentioned before on the podcast, but I've had multiple patients with severe anxiety. We located strep in the urine, treated the strep infection, and there's significant improvement in anxiety. So nothing's just in your bladder or your head or anywhere else in your body. We're one interconnected system. We're whole, and we have to start testing and treating us like a whole organism, not just individual parts. Let us know if there's anything else you'd like addressed in this context of infections. And remember to always have hope, because you were made to be whole.
Have a podcast question or suggestion? Text or call us on the podcast info line at 330-439-0686. Thank you for spending time with me today. If you like what you hear, please subscribe to be notified when new episodes release. And remember, you were made to be whole.